You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 3rd, 2017. This week, a TCT recap including ORBITA, Watchman, BVS, culprit shock, XL quality of life, and CTO. First up is the ORBITA trial. Wow, triple wow. The ORBITA trial has rocked the world of cardiology. The New York Times led with the headline, quote, "Unbelievable, heart stents fail to ease chest pain." Two editorialists writing in The Lancet along with the paper titled their editorial, quote, "Last nail in the coffin for PCI and stable angina." The small in number but extremely well-conducted ORBITA randomized controlled trial bravely randomized patients in the cath lab with stable angina and single-vessel coronary disease who had been maximally treated with meds to either a drug-eluting stent or no intervention. No intervention, sham procedure. The Lancet published this landmark study. The methods of the study are as beautiful as I have read in years. It's pristine. The blinding was extreme. The physiologic effort to prove that these were real lesions. The Lancet paper has pictures of the lesions, and these are not lesions that people walk away from. The pre- and post-testing of exercise times was exquisite. They also measured ischemic burden and quality of life. And in the end, friends, there was no significant difference in exercise time, angina symptoms, and quality of life. So, for those of you keeping score in the treatment of PCI in patients with stable coronary disease, we now have no reduction in MI with PCI, we have no reduction in mortality with PCI, and now we have no reduction in angina when compared against the sham. The implications of this study are huge. It's not only the billions of dollars spent on cath and PCI procedures, but it's also, think about the upstream's monies and efforts and fear for searching for and finding stable coronary disease. I see this every day. It's a head shaker. I'm like, has anyone read the COURAGE trial? Now, there's reasons to be cautious. There have already been many thoughtful notes of caution concerning the nuances of this study. As a writer, I spend a lot of time trying to explain nuances of study and tamp down excess excitement over small studies with important nuances. So in the ORBITA trial, a few of the nuances include the fact that these were low-risk patients with single-vessel disease who had a run-in period and aggressive medical therapy, about 3 meds on average. So that means that this doesn't generalize to acute patients or patients with more severe disease. Another nuance was that angina improved in the run-in period and many patients had low level of angina at baseline. So if you have lots of patients who have low levels of angina, it's maybe hard to show a difference. There were also small numbers, and certainly that affects our confidence in the statistics. And there have been already statistical fights online about the limitations of measuring changes in walk times. There's things like ceiling effects and regression to the mean that may be favored the sham group. Now, small studies should also be confirmed in larger trials. But you cannot criticize the investigators. This was a brave effort. They took patients off the table with greater than 70% lesions. This kind of study may not have passed IRB approval in the U.S. So therefore, they had to carefully select patients that they knew were low risk. Finally, there is hardly any doubt, though, that these findings transcend the non-benefit of PCI in stable coronary disease. It teaches us the crucial value of placebo effect and its ugly cousin nocebo effect. When we tell a patient, look, we fixed you, this has an immense positive effect. Similarly, when we frighten people about their disease or possible side effects of drug, this too has an immense negative effect. What a day in cardiology it was yesterday. This study will definitely require a column from me, so stay tuned. Next up is the BVS. Now, the promise of BVS, which is the bioresorbable stent or bioresorbable vascular scaffold, or sometimes called a dissolving stent, was that with time, the stent would disappear and benefits would be realized. At the TCT, long-term data came out, and no, it doesn't look like it's any different with more time. The studies included the 3-year results of the pivotal Absorb 3 trial and also Absorb 4. Recall, these trials pitted the disappearing biovascular scaffold against standard DES. TLF, or target lesion failure, was 3% points higher with BVS in the Absorb 3. BVS also had higher target vessel MI and target vessel thrombosis, which is a dreaded complication of PCI. More patients in the BVS group required repeat revascularizations, and the data was going the same way in Absorb 4, and Absorb 4 enrolled patients with troponin-positive non-STEMIs with higher rates of target lesion failure. Now, these failures come on top of earlier Absorb trials, and it's also noteworthy that in March of 2017, the FDA issued a warning on Absorb 3 2-year data had higher major adverse cardiac events. In May of 2017, its use was restricted in Europe, and in September of 2017, Abbott halted sales of first-generation Absorb BVS. At TCT, interventionalists discussed the need to press on to second-generation resorbable stents. And I say, well, perhaps, but another lesson here is to look back on how this device got through regulatory approval and placed in thousands of patients. Wall Street Journal covered a story on the unproven stent. In my cath lab, so many were excited about those stents' promises. But the signals were there, we just had to look. I'm not against progress, but safety should come first. Third topic is Watchman and Prevail. Now, 5-year results of the Prevail trial, which compared the Watchman device against warfarin, were presented at TCT and simultaneously published in JACC. The Watchman trial has combined Prevail results with those of PROTECT-AF in a patient-level meta-analysis for the same paper. Their conclusions were positive. You will hear that Watchman has now made non-inferiority in the late ischemic efficacy endpoint of Prevail. In the previous analysis of Prevail, it did not make non-inferiority. This new data, however, does not change my take on left atrial appendage closure as a stroke prevention strategy. I remain unconvinced, and you should too. I have a column in press on this topic. I say in press because I'm really blessed to have an incredibly smart, thorough, detail-oriented editor who helps me a lot, and we're going to try and make it as clear and concise and accurate as possible. Much of my contra-argument that will come out will parallel arguments that I wrote in an editorial with Dr. Andrew Foy and Gerald Nacarelli of Penn State University, and that paper is published in Heart Rhythm. So a brief synopsis of the findings of this most recent presentation was that Watchman did meet non-inferiority in the late ischemic endpoint, but it was barely. But it missed non-inferiority in the other efficacy endpoint. The other points to make is that this new data did not change the directions of the trends in the data. It does not quell concerns over the risk of antiplatelet drugs required to prevent device thrombus. And it doesn't change the dubious pathophysiologic basis for appendage closure. In the column that's in press, I'll go over and try to simplify the statistics of the new findings. There are many arguments against left atrial appendage closure that these new findings do not change, so stay tuned. The next topic is an important study called culprit shock. This was the first study presented on the first day of the late-breaking clinical trial sessions, and it examined the treatment of patients with acute MI complicated by cardiogenic shock. The New England Journal of Medicine published the findings, and it was yet another victory for less is more medicine. That's right, less is more. The main question of the culprit shock RCT was whether one should perform PCI of the culprit vessel alone or aim for maximal revascularization in patients with multivessel disease and cardiogenic shock. The idea is that if you do multiple vessels, you'll improve blood flow and perhaps get the patient out of shock faster or more effectively. The primary endpoint of this study was mortality or renal replacement therapy. The results strongly favored the strategy of doing only the culprit vessel, which to me makes sense because the extra time and contrast load probably outweigh the benefit of more complete revascularization. What's more, this finding does seem to align well with previous studies. One caveat, though, which veteran journalist Steve Stiles points out in his really excellent coverage, was that the trial protocol encouraged operators to do CTO lesions. So this, in the group that had multivessel PCI and aimed for complete revascularization, doing CTO lesions may have biased the results in favor of the culprit vessel only. Most of the discussants at TCT downplayed this caveat, though. The next study at TCT is called the Excel Quality of Life Study. This was also presented on the first day of TCT, and it was an important sub-study from the Excel investigators. Remember, Excel was an RCT comparing PCI with drug-eluting stent to CABG in patients with left main disease that was suitable for intervention. The primary endpoint came out pretty similar. I qualify similar a bit because purists will point out that CABG looked better if not for the way MIs were adjudicated, and also another study at the same time as Excel, the Noble study, slightly favored CABG over left main PCI. But in general, the PCI and CABG for left main disease looked pretty similar. But this sub-study, this Excel sub-study, was novel because it presented results on quality of life data. Quality of life data is special because it's patient-reported, not doctor-reported. The results here were that PCI gets a slight edge at 30 days, not surprisingly, but after that, and up to 3 years, angina, dyspnea, physical functioning, and depression scores were similar in the PCI versus CABG group. The study is not only important on its specific merits, but it's also important because it heralds the beginning of a new era in which patient-reported outcomes will become an important measure of value. The Heart.org Medscape Cardiology journalist Patrice Wendling has an excellent news story, and I wrote a column on this story. One of the things I learned from the session from the trial discussant John Spertus, who is a massive voice of reason, is that just recently the FDA will now allow results of the KCCQ questionnaire help determine medical device approval. So how patients feel, quality of life, will become an important metric for approving devices. That's a big change because to date, only hard endpoints have been used for device approval. The final topic today has to do with chronic total occlusion intervention, CTO. At TCT, we heard yet another cautionary study on CTO. Remember, at ACC earlier this year in March, there was a great buzz about a study called Decision CTO trial. This Decision CTO trial was from South Korean investigators, and it found that CTO was no better than optimal medical therapy in reducing the composite of death, MI, stroke, or any revascularization at 3 years. At TCT, German investigators presented the results of the REVASC study. This was an RCD of mandated PCI of all CTO versus PCI or no PCI at the operator's discretion, but no CTO. The mandated PCI did not lead to improved LV function, either regional or global. That's key because remember, CTO advocates say that it helps improve LV function. Steve Stiles has a news story and it documents many caveats of this abstract. But still, this is another study of CTO which does not confirm much in the way of benefit. We certainly need more evidence concerning this pretty high-risk procedure. So that's it for This Week in Cardiology and a TCT recap. I'm grateful that you listened. Thank you. See you again next week. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.